So in the second presentation, we're going to look at the management part of the story, the available guidelines, some of the recent data on safety, particularly as they affect paracetamol and the non-steroidal anti-inflammatories, and then move to alternative approaches, including enzymatic therapy. So you've heard that this is the commonest form of arthritis worldwide. Global prevalence of knee involvement is around 4%, 250 million people around the globe. You've also heard about the heterogeneity. You have symptoms, so that is joint pain, stiffness, and loss of function. You have structure, which is imaged by radiology or MRI, and then you have actual anatomical pathology. And it's a Venn diagram between those three, but suffice to say that the pain and stiffness, the symptoms leading to functional decline, make this the form of arthritis which contributes greatest to the global burden of disability. And hip and knee OA across medicine are the 11th highest such contributor. And the years lost to disability for OA will rise by over 60% over the period that we've just gone through, and will rise by 40% over the subsequent decade and a half, the decade, of course, of healthy aging. Now, if we look back at guidelines, these almost attest to the absence of structure-modifying osteoarthritis drugs that genuinely alter the rate at which cartilage is lost and the subchondral bony reaction responds, leading to joint failure. And most of the drugs that we have are symptomatic. And so the guidelines over the last 15 years attempt to give a pyramid of use of symptomatic therapies. So if we were to use the 2012 ACR guidelines, non-pharmacological measures, including exercise, weight loss, psychosocial interventions that you heard about from Dr. Enrotin just at the end there, self-management and self-efficacy programs, physical therapy and walking aids, a stick, perhaps patella taping for knee osteoarthritis. These comprise the base case scenario. You then add paracetamol or acetaminophen with topical NSAIDs. You then move to oral NSAIDs, including the COX-2 inhibitors, and then surgical referral with opioids at the very top of this pyramid. In the OARSI guidelines in 2014, they classified the measures after you got core treatments with those that are in patients with OA without comorbidities and those with comorbidities for the knee alone, and then multi-joint OA without and with comorbidities as the different classifications. But at ESCAO, we wanted to focus on a care pathway for OA that could be used by primary care and secondary care practitioners. So we have the non-pharmacological and pharmacological treatments initially, with the core set being education and joint care advice, weight reduction, and exercise regimens. We then move, if symptomatic, to paracetamol or chronic slow-acting symptomatic drugs, principally the combination of glucosamine sulfate with chondroitin sulfate. If symptoms persist, we add topical NSAIDs, and then if they persist still, we move to the oral NSAID and COX-2 component of the therapeutic regimen. If there is still symptom persistence, intra-articular hyaluronic acid and intra-articular glucocorticoids, and then only to short-term weak opioids and duloxetine, before going on to surgical referral, total joint replacement, or unicompartmental or hemi-arthroplasty. And it's in these different steps that I want to focus today. I want to cover more recent data on the use of paracetamol, and I want to cover recent data on the applicability and safety of the oral non-steroidal anti-inflammatory agents. So first of all, paracetamol. We start with this meta-analysis following a systematic review in the BMJ in 2015. Undoubtedly, in this review of 13 trials using paracetamol for hip and knee OA, there is a significant and borderline clinically important impact on short-term pain and short-term disability, and an effect size that averages at 0.14. However, there was, even at this early stage 6 years ago, concern about adverse events. There was no overall difference between paracetamol and placebo in these 13 trials in the adverse event rate, but there was an elevated risk ratio approaching 4 for hepatic adverse effects. There was then, a year later, a more thorough review of safety undertaken by the group at Leeds, and I'll summarize that for you here. For overall mortality, there was a significant 28% increase in all-cause mortality that remained after you adjusted for a variety of confounding agents, and that was observable for first prescription according to longer gaps between prescription, repeat use, and repeat use with high medication persistence and possession ratios. For cardiovascular events, there was an increased risk for all events, even from as low as 1 to 2 tablets weekly with a risk ratio of 1.19. And when you got to more than 15 tablets weekly, it went up to 1.68. When you looked at upper GI adverse events, there was a significant excess with a relative rate of 1.36. And as important, perhaps, or more, for lifetime cumulative intake on renal adverse events, the odds ratio went up for the lower cumulative dose 100 to 499 grams, 1.8, for 500 to 2,999 grams to 2.23. Both of these statistically significantly elevated. So these studies revealed a striking dose-response relationship between paracetamol at standard doses that we use for pain relief in OA and adverse events that are often observed with NSAIDs, including increased incidence of all-cause mortality, cardiovascular, GI, and renal adverse events. There was a benefit with a small effect size, as I said, of 0.14 in most of these studies when amalgamated, but the true risk of prescription may be even higher than is currently perceived in our clinical community. And it's noteworthy that at the end of 2017, the Safety Committee, PRAC, of the European Medicines Agency endorsed the recommendation to suspend the marketing of prolonged release paracetamol products with the statement that the longer acting product advantages do not outweigh the disadvantages, particularly when overdoses are also considered. And these will remain suspended until evidence can be provided of a reversed risk-benefit balance. Now let's move to the non-selective NSAIDs, which are the next tier. And of course, the main side effect we're aware of over the years is upper gastrointestinal intolerance. So in this systematic review and meta-analysis from 8 years ago in The Lancet, we have diclofenac versus placebo, ibuprofen versus placebo, and naproxen versus placebo, and you can see the progressively increasing rate ratio for upper GI intolerance, 4.22 in the case of naproxen. When we combine an NSAID with a PPI, a proton pump inhibitor, omeprazole, lansoprazole, etc., and compare that with a COX-2 inhibitor, we see that we get pretty similar alterations in upper GI toxicity. So combining with the PPI leads to approximately the same improvement in GI toxicity as a COX-2 selective inhibitor or specific inhibitor gives you. And if we look at naproxen, ibuprofen, diclofenac, and celecoxib in terms of their tolerability, celecoxib is clearly associated with a lower cumulative percentage withdrawal than naproxen and ibuprofen are. Now let's go to cardiovascular adverse events. In the same format, diclofenac, ibuprofen, and naproxen, we find that the higher cardiovascular intolerability rates are for diclofenac, 1.85, and for naproxen, 1.87. And we find, of course, that the COX-2 specific inhibitors vary according to the type. So rofecoxib is clearly associated with an elevated risk of myocardial infarction and of a composite cardiovascular MACE type outcome, whereas celecoxib actually has a non-significantly reduced, but towards reduction in direction, risk of stroke and composite cardiovascular. And probably the best RCT data from the Precision trial, 24,000 patients randomly assigned to celecoxib, naproxen, or ibuprofen, and then followed forward over 34 months. You can see that all-cause mortality, cardiovascular, GI, and renal events all favour celecoxib, with a variation in the non-selective NSAID sort of hierarchy thereafter. But non-inferiority was observed for celecoxib with ibuprofen and naproxen when it came to cardiovascular safety. So paracetamol is associated with increased mortality and risk of cardiovascular, GI, and renal adverse events. More careful consideration of its use is required in OA. The non-selective NSAIDs have potential for both toxicities, while COX-2, particularly rofecoxib, gives the potential for cardiovascular. GI toxicity is modulated by celecoxib, which is less toxic than the non-selective NSAIDs. Cardiovascular seems particularly a problem with rofecoxib, and all of these drugs need to be used a little more judiciously in OA for defined periods of time, as you've heard in the first elegant presentation, perhaps when inflammation is at its peak. So now just closing out with some of the other unexpected adverse effects which emerged in a more detailed systematic review and meta-analysis that we published in Drugs and Aging a couple of years ago. This took us from 2,149 studies in the literature to our combined group of 73 reviewed within the meta-analysis. And in addition to all adverse events, GI and cardiovascular, there were CNS, dermatological, renal and hepatic, and all-cause mortality. Just a taste of that meta-analysis herewith. So for upper GI symptoms, no surprises, except that in addition to dyspepsia and ulcer, abdominal pain was also apparent. For cardiovascular adverse events, we found that hypertension, which hadn't emerged in the previous systematic reviews, was a noteworthy cardiovascular complication with a significantly elevated risk, even with the COX-2 inhibitors, as was when rofecoxib was removed, persistence, but some attenuation of that elevated risk. Heart failure was important, with a relative risk of 1.68, as were, of course, peripheral and generalized edema, and these also stayed when rofecoxib was removed. We found that, in addition, for drug-related adverse events overall, for COX-2 versus placebo, the relative risk was 1.26. The ones that I've discussed are shown in the remaining rows of this particular table. So what other options do we have? Time does not permit me to talk about glucosamine sulfate with chondroitin sulfate, but that has been carefully reviewed in our SKO working group reports and in the published literature, and suffice to say that prescription grade crystalline glucosamine and chondroitin preparations certainly appear to provide a useful adjunct in pain relief. We also have a sound database for intra-articular glucocorticoid injections for transient relief of inflammation, particularly in association with aspiration of effusions in the knee. And we have a positive benefit-risk balance in some circumstances for intra-articular hyaluronic acid derivatives, particularly those of higher molecular weight. But in closing, I want to touch on an innovation in this therapeutic armamentarium, oral enzyme therapy. The combination of bromelain, trypsin and rutoside, which are of course the first two routinely encountered enzymes, but the third actually a quercetin like agent, which has, as you are aware of, senolytic capacity also. And these agents together have both anti-inflammatory and senolytic potential. So the efficacy, tolerability and safety of this oral enzyme combination has been compared with diclofenac in osteoarthritis. You see here the change in Lacane index over a period of weeks since baseline, attributable to the oral enzyme combination, and the magnitude of that change over the baseline to end of study periods. And you see the same responsiveness for oral diclofenac. And there's really very little to choose between these two, and of course a markedly different adverse effect profile. And that is summarized in this last slide, where the oral enzyme combination and diclofenac over 3 to 12 weeks showed comparable efficacy with clinically relevant improvements in pain and pain-related function, but that laboratory data from the blood samples taken at baseline and at the end of the study show virtually no changes in the oral enzyme combination group, whereas in the diclofenac group, there was alteration in key hepatic enzymes and in red cell parameters, suggestive of both pro-inflammatory and hepatocellular effects. And this favourable benefit-risk profile suggests that the oral enzyme combination might well be an alternative form of intervention in patients with osteoarthritis who are at high risk of non-steroidal anti-inflammatory complications or of adverse events from paracetamol use. So with that, I'd like to thank you all for your attention and to welcome questioning on this new and exciting area of clinical practice. Thank you very much indeed.